Fantastic. Right. We are live on World Sports Chiropractic Chat Show. And today is episode, I believe, 16. And I have the distinct pleasure and really, to introduce a gentleman called Ryan Kendrick from all the way from Vanuatu. And Ryan obviously is on the show because Ryan is the inventor, should we call it, of dynamic tape. And of course, dynamic tape being a partner of FICS, and we've been working together for a good few years now. And I thought, you know what, we need to have Ryan on the show and explain us chiropractors a little bit as to what the tape is, what it does, how to use it, and to give almost like a little bit of a dummies guide to dynamic tape. So Ryan, thank you, man, for joining us. Welcome on the show.
Yeah, thank you. No, brilliant, Mika. Thanks for having me along. I'm excited about it, actually.
No, that's great, man. No, we've tried a couple of times already beforehand, but the weather has been a little bit upsetting in Vanuatu. So you guys have some internet temperamentalness, should we call it, with the weather.
Yes, look, we're in a fairly remote location here in the middle of the South Pacific. For those who don't know where Vanuatu is, and it's a developing country, so it's not always the best. And I'm not even in the centre of Port Vila, which is the capital. We're outside of town as well, so we're reliant on the weather. Sometimes, if all the clouds come in and the rain comes in and the wind, then it can move towers or antennas around, and things can get disrupted pretty quickly. So we're all good today, I think. Yeah,
today is looking promising. We are both in clear focus and and obviously ready to rock and roll. But hey, you know what, Ryan, you are the very first should we call it non-chiropractor on the show. So
you can say the word, I think, Mika, it's okay.
Yeah, you're a physio. Come on, man. Yeah. That's more than you think, man. But I personally like working with physios because there's always, tricks we learn from each other. They teach me stuff, I teach them stuff. Oftentimes there's a slightly different way of looking at things, perhaps, but in the end, we always get there, and the patient gets better, or the athlete gets better, which is the more important thing. But tell me, so what brought you into working with chiropractors to begin with?
I've worked with chiropractors in a range of sort of situations over the years. So my background as a physiotherapist, and I have a master's degree then in musculoskeletal physiotherapy, and work predominantly in elite sport. So I worked actually in the UK for a number of years with the Essex County Cricket Club. And I also worked with Greg Rosetsky, who's a British tennis player, former number 4 in the world, and his role on the British Davis Cup team as well. And so that was one side, was with a lot of the elite sport in Australia. I worked a lot with our swimmers and a range of different sports. The second side was teaching on the master's and undergraduate program, the clinical side of things in musculoskeletal physiotherapy at Griffith University, or for the Griffith University students, which is the Gold Coast. And then the third side was in private practice, predominantly with either chronic spinal complaints, but chronic musculoskeletal things, or those elite athletes once again. And so in that role, particularly with the elite sport, but also in clinic, we had several multidisciplinary teams, that we worked within. And also, as the dynamic tape side of things has taken off, obviously chiropractors have seen opportunities to meet some of their clinical aims, just as we did when we were developing it, And so, it's just led to, we've got some fantastic chiropractors on board with us who teach for us, some out of the US, Nick Studholme, who I'm sure some of you listeners know, Todd Riddle, David Benevento. So there's a number of guys around who, and I'm missing some out. There's some great guys in Australia as well who work with us and so on. So, look, it's been really exciting. As you said, I always love not even working with those guys, just having a meal. I always, you know, when I'm in the US, if I'm in Colorado, I'll catch up with Nick Studholme, and I learn something every time. And you know, we think very similarly, actually, surprisingly, or probably unsurprisingly, I think.
Yeah, quite.
You know, I really do think that the more you sort of, wouldn't say specialised, but the more, you know, the more well-read you are, and the more you're looking into things and asking those questions, why is this going on? How do I guess, I always found that difficult patients were, you know, the ones that weren't getting better was my motivation, not the ones who did. You know, it's
yeah,
the ones
exactly.
who did aren't the ones who keep you awake at night thinking about it. It's the ones who aren't, where you go and you talk to those colleagues who are maybe looking at things a little bit differently to you. You get back, your head back in the books. You know, you're looking at different sort of resources. And so, yeah, I really find that you know, talking to these guys, it just, you know, just looking at through another set of eyes, I guess. It's fantastic.
Yeah, exactly right. And I mean,
but as I say, the more that you read across the disciplines, the closer we get. I think, you know, as I say, when Nick and I, although we've started very differently, and yourself and I as well, some of the conversations we've had, I think, you know, our focus and our aims and our thought processes are very similar. We may have a few different tricks up our sleeves and different interventions that we may use to meet our aims, but the way that we sort of work through the process is probably relatively similar.
Absolutely. Well, I mean, you know, when you come to think about it, though, it's only one body. You know, all bodies, you know, we follow kind of the generic blueprint, you know, where you have a skeletal structure, then you have, of course, muscular tissue that is integrates ligaments, tendons, you know, whatever, fascia, all covered in a skin sac. And then, of course, you have the electric wiring in there, which is the nervous system. Then you got your plumbing, which I'll leave to plumbers. You know, I'll leave that to the experts. You know, I won't touch plumbing. But you know, electrics, mechanics, I'm happy to meddle my way through those. And at the end of the day, you know, how many different ways can you treat it, right? You know, whether it's chiropractic or osteopathy or physio or acupuncture or you know, whatever, Reiki, you know, it's all kind of aimed, you know, the aim is the same, is to benefit the patient. And therefore, I suppose, you know, we may receive a different education in university. But then again, when we start, like you said, you know, reading up on it, looking around the subject matter, you know, figuring out, okay, what does it actually do? You know, then that's where the merger comes in, isn't it? Everybody just kind of migrates towards the same thing.
Yeah, look, and I think, you know, if you look into a lot of the pain science side of things, you know, one thing that we know has a big influence on the pain experience, you know, if we take away some of the psychosocial things, but one is you know, sensory input from the periphery, and that's what we're very good at changing, whether it's through our manual techniques, whether it's even through our exercise and changing the way, you know, people are moving and loading, and the information that, you know, that afferent input that's coming back in. So, you know, from even, you know, some of the work that we probably do cognitively as well, or you know, using people's vision to look at things, taking people's vision away. You know, we're always modifying that sensory information, which gives a different output from the brain in terms of interpreting the meaning of that. So I think there are many ways to do that, from whether it's a needle, whether it's your fingers, whether it's, you know, a tape, managing some of that loading to reduce that. You know, there's lots of ways to address some of these things.
Or duct taping some TheraBand around your arm.
Well, yes, we tried that as well. Yeah, absolutely. Yeah, that's sort of, I guess, a precursor to the dynamic tape is, you know, taping inner tubes from tyres, bicycle tyres and TheraBand and all these sorts of things to try to get the effect that we were after.
Absolutely. See, that's one of those things I really admired, you know, when I heard your sort of creation story, should we call it, for the first time. You know, how there was a gap in the market, you know, that the product you wanted didn't exist. You know, you didn't, there was no such thing that, you know, you had your rigid taping, you know, you had your kinesio taping that does something different, but you didn't have a tape that would help with the load dissipation. You didn't have it, that just didn't exist. So hence, in comes the creative genius and start slapping the inner tubes and dirt bands and whatnot, with duct tape. But obviously it's a bit crude and a bit cumbersome. So
yeah, look, and as you say, it was sort of that, we never sort of set out to create a tape company or as you say, there was a distinct gap there, but that gap for us was a clinical gap. It wasn't we weren't going, oh, there's a gap in the market, let's go and do that. It was sort of, we were trying to solve problems for our patients. We know that load is a key driver of a range of pathologies. We'll keep pain aside for the moment, but our tendinopathies, load is a big issue. But we know we have to load people to get that recovery as well. So we have to manage it fairly specifically. And sometimes, just normal activity, not even their sporting activity, but just walking around or whatever else was too much load. And we wanted to be able to sort of do some of that work externally to reduce that load and settle things down, and then reintroduce the load in a way that they could handle it and with adequate adaptation and recovery periods, and so they could build that capacity, successfully. But we also didn't want to take them off it. For example, what other options did we have? We could rigid tape it, but that had limitations to it. We could put a brace or maybe a walking boot if it was an Achilles or something like that, or get them on crutches or something. But then you lose the load almost entirely. You're not going through full range of motion and getting normal gliding and sliding and other things that just put functional stress through the tissues without overloading it. So we wanted that functional load because of all of the really important things that happen with our mechanotransduction and all those sorts of things. But we didn't want to overload them, and we didn't want to wind up the pain system, and we didn't want to do all these other things. And also we found, often if we did use a rigid tape in our athletes, then they simply couldn't get into the positions they needed to get into. If we're taping the shoulder, it would just rip off after a little while, or they would just, it was too uncomfortable. And as you know, with your elite athletes, if there's anything sort of playing on their mind, that's a big thing. They've got to feel 100% confident with whatever's on there. And at the very least, you're going to be the reason that they lost if there's something on there that they didn't like. So you don't want to put yourself in that situation. So it was finding something that was, really worked, that allowed that full range of motion, but could create a genuine mechanical force into the system to decelerate movement, to do some of that work, particularly in that eccentric sort of lengthening, landing, decelerating, throw, all those sorts of things. Or that we could use to change kinematics. So we're sort of talking about two different things, I think. One is the kinetics. Can we just get in there and adjust the force by adding another force, in parallel, essentially, externally, like we do with a dynamic splint. And that's where the name actually came from. It wasn't sort of thinking, oh, it's moving. It was actually thinking, with our flexor tendon surgeries, they'll have the splint with the rubber band coming down so they can actively extend against it because the extensors are intact, and it allows that nice movement and gliding of the tendon so we don't get some scarring, a little bit of load through it. But it springs them back so they're not contracting and pulling on that flexor tendon. And so it was that same idea. Can we use something externally to do some of that work but allow full range? Obviously, there's limitations with splints, and you can only put them on certain parts of the body and can't use them in sport because they're hard or whatever else. So that's where the name came from, dynamic splint. And I was working with the sport, as I say, and the musculoskeletal side of things. My wife, Ylva, is a Swedish trained physiotherapist, and she was working predominantly with children with the neurological issues. And so again, was looking at changing movement patterns to improve function, particularly, can we get thumbs out of palms and wrists up to create a functional grasp, or, they're tripping over their toes with a foot drop or something. Can we get the toes up but not lock up the ankle so they can still, adjust to the ground surface, or use their balance strategies and invert and evert and all those sorts of things? Because as soon as we lock it, we start to lose some of those normal things. Even with your ankle sprains, you don't want to lock them. It's not even getting to the end of range that's the issue. It's just getting to the end of range with a force that's beyond the capacity of those tissues to deal with. So we can get to end of range, but we just need to moderate that force a little bit, so they're not breaching their threshold. And that's sort of what we were trying to do, and so that they can fine tune. And there's certainly some studies on the ankle that show that if you do use rigid bracing or taping, that they're less stable in a sense. Or, you know, if you have people stand on one leg and close their eyes, they're more likely to put the other foot down because they can't fine tune within physiological normal. And that's what we didn't want to limit, you know. So
yeah, absolutely. And therein comes I think if we take a couple of steps back, you know, from where we are now, you know, you talked a lot about the afferent input and a little while ago, and I think that's, you know, coming from having made observations among my colleagues, should we call it, you know, a lot of chiropractors, I think nowadays, you know, the sort of, should we call it, division between afferent and efferent input can be a bit blurry for a lot of people, a lot of my colleagues, and maybe that's not very well understood, or maybe it's not very well taught in college, I don't know, or maybe the emphasis is not there. But you know, personally, when I look at patients, you know, I always think, okay, if there's a dysfunction, you know, why is this brain not understanding what's happening? You know, what's causing it? And I think, you know, what therein lies the beauty of dynamic tape, because you know, it's not only mechanical, of course, like we discussed the other time. You know, it's not only a mechanical tape, but there's also that, call it proprioceptive, call it neurological effect, where, you know, just getting those tissues to actually move creates that stimulation in the brain.
Yeah,
the recovery process goes on.
Yeah, absolutely. And I think there's, you know, you can't put a tape on, you know, and contact the skin without changing things. You know, there's been some studies done previously where they look at brain imaging, you know, functional MRI type of things, and they'll just put a little piece of tape. One study comes to mind, a little piece of tape over the patella, not trying to do anything mechanical, just literally putting a piece of tape on there, and they were doing proprioceptive repositioning tasks. And, you know, with the tape on, the brain lights up differently. Now, so we know that we're having an input in there in some way. Does that mean it's a clinical benefit, or maybe it's detrimental? You know, that's not saying, all it's saying is it changes things. Absolutely. I think probably, you know, that if you look at the research on tape in general, if our main aim is to have a neurophysiological effect, can we facilitate muscle? Can we inhibit it neurophysiologically? I don't mean facilitate it by improving position and length tension curves and things like that, because we can do that. People tend to think of facilitate these days as a neurophysiological thing, but, you know, rather than just an overall assisting, enhancing type of idea. If you look at the research on that, it's pretty, what would you say, a bit inconclusive. You know, there's certainly individual studies that might show something, and others that show the opposite. So that's quite conflicting. There's differences in people in pain to those not in pain, you know, necessarily. For example, some work on the Achilles with the kinesio tape. They looked at the Hoffman reflex. So basically the motor neuron pool excitability, and they showed, I think this was Jeremy Lewis and some others who did this, and showed that in asymptomatic people, there was a slight facilitation. It's quite interesting, if I remember it correctly, a slight facilitation once the tape was removed, interestingly enough, in asymptomatics, but in symptomatic Achilles tendinopathy, there was no change, and there was also no change in functional sort of, you know, jump distances or whatever they were looking at. And, you know, we used to do these sorts of things with our conventional tapes or pre-kinesio, you know, I'm sure lots of people, lots of your listeners have probably done that, you know, say for lower trapezius, where they might have been taping from the scapula across towards the spine with a fixamol or a coverall in the US and a rigid tape over the top. And sort of the conventional wisdom at the time, I think, was that if you tape along the line of the muscle, you would get more of a facilitatory effect. And if we taped across it, often people go quite firmly across levator scapulae or something, that some of these downward rotators they thought were overactive. And so if we went across it, we would get, you know, inhibition. If we went along it, we get this facilitatory effect. And a group out of London, actually, led by Dr. Carolyn Alexander, they looked at that as well. And they looked at Hoffman reflex once again, and they taped along lower trapezius compared to across lower trapezius. And they found that actually taping along it created inhibition rather than the expected facilitation, and taping across it didn't change anything. And then they did the same on the calf and found the same thing.
Okay.
Now, that's not to say clinically that when you put it on and your person lifted their arm up and they went, that's fantastic, and you went, you know, give yourself a pat on the back, I'm brilliant. It's not saying that the person wasn't better. Clearly they were, but not because of a facilitation at a motor neuron pool level, most likely.
Sure.
Now, again, how does that vary in asymptomatics versus symptomatics and so on? That might change. So my point is, with the neurophysiological side of it, we know we change things. I don't think we have a very good grasp of how to manipulate it to clinical effect, you know, at this stage. I think there's more work needs to be done there. You know, the different muscles behave differently. We know that muscle rolls are different. Some are real stabilizing muscles. Some are very torque producing muscles. We know that they change when they're in pain, and the more stabilizing ones tend to get switched off a bit. The big movement ones tend to kick in a bit more. So maybe the same is occurring, you know, in response to that input from a tape, if you're looking purely neurophysiologically. So that's why we sort of stay pretty, you know, our clinical reasoning and everything is based heavily on that mechanical side, because we know that load is a key factor in some pathology, and we know certainly lots of pain is load dependent. If you're looking at an ankle sprain or something like that, where it's, you know, there is tissue damage, there is nociceptive drive, you know, the more you stretch it, or, you know, the more it's going to hurt. That's fairly typical. We do use it in some of our persistent pain cases where that's not such an issue, and there are other changes going on in the nervous system and so on, but we use it very differently in those cases. Yeah, so it's you know, as I say, and for function, as I say, you may not even have pain. It might be the foot drop, and we're just trying to overcome gravity, you know, so that they're not catching their toe when they're walking and things like that, or getting the grasp going, or and so on. So it depends on your patient population a little bit, but it's not. We're not particularly pain centric. We're very aware of the pain processes, and I think that's critical to know what is going on from a pain perspective when you're doing it. We have a thing that we call the load capacity equation that we developed to just help the clinical reasoning, you know, through this, you know, what is going on a little bit. And it's quite a big expanded diagram, so it's a bit hard to explain. But basically what we're saying is, you know, does the load, you know, that's imposed on the body, is that load beyond the actual capacity of tissue? So our equation is load over capacity. And so what we're talking about is the load can be, you know, so many factors in that. The type, you know, is it mechanical, thermal, chemical, the magnitude, velocity, also the rate of application of the load, the frequency, is it sustained, is it repeated, is a, you know, intrinsic load, extrinsic load, all of those things that factor into the loading. Then our tissue capacity is broken down into two things. It's the structural integrity, so is there tissue damage, if you like, and then the conditioning, because you can have things that are structurally intact but just aren't conditioned for the load that you're imposing, and that's also going to, you know, start signaling off problems and pain, and potentially lead to tissue damage if you keep going. So we break all those things down, and then on the other side of the equation is this perceived capacity. So if everything's good, you know, and we have a load, you know, of 1 and a tissue capacity of 1, and that should equal 1 on this side. But what happens at times is that, you know, through that central wind up or through psychosocial factors or whatever, essentially the goalposts are shifted so that we're no longer at a 1 on the perceived, what the body or what the tissues think or what the brain thinks, but we're at a 0.5. So all of a sudden we've got no tissue damage or very little ongoing tissue damage, ongoing nociception and so on. We've got a load that they should be able to handle, but the goalposts have been shifted now, and the body is saying, or the brain is saying, no, we can't handle that, and we're still getting pain or maladaptive movement patterns and all these other things. And so then we have to come in and start on that side a little bit, rather than that direct load management or direct, you know, tissue-based sort of treatment. So we factor all those things in with how we would use our tape, the preparatory education, you know, whether we're using it to try to reduce threat and encourage a movement and teach people how to move again and address these maladaptive movement patterns that they might have, or whether we're literally coming in and just going, you know what, that's overloaded, let's take some load off it, settle things down, reintroduce that load, settle down that nociception, that primary hyperalgesia, and so on, and go that way. So we need to know the pain processes at play. Is there tissue damage or not? You know, what movements particularly are perhaps leading to that breach of that threshold of those tissues, and so on and so forth. And then we can develop an effective taping technique. So there's no recipe, which is often what people want with tapes. Oh, well, how do I tape? How do I tape for, you know, a patellar tendinopathy? And I'm like, well, I can see 5 different people and tape them in 5 different ways.
Yeah,
because it depends on all of those things. And it's one of my little pet peeves, I guess you'd say, with some of the research, is that sometimes, probably unknowingly, what they're really looking for, particularly when it comes to low back, you know, pain, because that's quite a difficult subject to research. They're almost looking for a panacea rather than a logical, clinically reasoned approach, because they'll say take 150 people and the only way of sort of categorizing them, if you like, is to say, well, they've all had it for longer than 3 months. It doesn't extend past the buttocks, so they're all the same. But at the same time, they're non-specific low back pain. So to me, that's a lack of diagnosis, not a diagnosis in itself. And so sticking the same thing on those 150 people and expecting, whether it's mechanical, whether it's a traction, whether it's a mobilization, whether it's an adjustment of the thrust manipulation, whether it's electrotherapy, whatever it is, you know, they're not the same. And particularly when it comes to taping, they're going to be very different. And they could, you know, some may have some ongoing tissue damage and be primary hyperalgesia and we need to treat one way. Some might have a lot going on from a psychosocial perspective and a fear avoidance and all these other things that we need to start very differently. And so, yes, I think we have to be very careful when we critique some of the literature as well, because, you know, there is no recipe to just go, for every low back pain that's got it there, we're going to stick a couple of pieces here and magically that's going to fix everybody. You know. Oh,
wow. What are you telling me that it's not a cookbook approach?
It is certainly not. I may have said that once or twice before. Yes, it's not a cookbook approach. Absolutely.
Oh, so you can't just like generalize everyone into one category and just do the same thing for. Oh, I'm actually a little bit disappointed.
You know, you do actually. You know, much to people's disappointment, I guess, you do have to actually think about it, and the more you think, the better your results. It is. We do say, look, it's the thinking clinician's tape, and you know. And that's what I love about it. You know, as I said earlier, a lot of my private practice work with really chronic, you know, persistent pain cases, and they're the ones that, you know, as I say, they keep you going. You know, they're the ones that really keep you thinking, and you know, you have to have a fairly very reasoned but logical sort of systematic approach to those, because if you jump in and do a whole lot of things, then they're worse or better. You don't know what's done what, or even worse, nothing has changed. Then you know that's even worse. I don't mind making people worse, because then at least it's leading me in a direction. I know that we've done something. So yeah, you can always, you know, use that information, feed that back into your reasoning and modify things if you can change it one way or the other. So yeah, absolutely. It's always going back, isn't it, and asking that question, why? You know, why is this?
Another why.
Absolutely. Again, with the tape, you know, people say, oh, you know, how do I tape for this? And I'll say, well, what's your aim? And they'll say, to reduce pain. And I'll sort of say, well, that might be an aim of your overall treatment, if you like, and one of your patient's goals and everything else. But for me, from the taping perspective, it's a possible consequence, maybe, rather than my aim. I have to know that there's a very clear deficit. What is the deficit that you're trying to address, and what mechanism, by which mechanism can the tape address that? You know, and don't tell me just by having tape on skin, because as we said, that's a bit vague. We don't know that necessarily. So I need to know, look, when they jump and land, they're collapsing into, you know, hip adduction, internal rotation and knee flexion and so on. And, you know, they're at maybe an ACL reconstruction patient that's going back to sport. And we know certainly the research would suggest that that's, you know, increases their likelihood of secondary non-contact ACL injury from having that dynamic valgus type of movement pattern. So, okay, great. So then people sort of go, well, let's jump on and tape the hip and stop them collapsing in. And I'm like, well, hang on, let's go back a second. Why are they collapsing in? Their glutes might be fantastic. It might actually be they've still got poor quads. So when they land, they can't control that load in the sagittal plane. So what do? You give in the frontal and transverse planes as well, at the foot and at the hip and knee. So, or at the hip as well. So then maybe we need to come in and do a knee extension that really resists the knee collapsing into flexion as they land. And we've seen this, somebody sent us some information using Dorsavi. I don't know if you've ever come across that, which looks at 3D sort of kinematics. A great device that looks at, it's got like little accelerometers that you can put on. So it picks up your movement, but also with EMG combined with some of the units that they have. Anyway, somebody sent us exactly this, actually. They looked at somebody who wasn't an ACL, they had a L3-4 nerve root compression, so known quads deficit. And they first taped the hip and did a jumping landing, hop, single leg sort of landing task. And sure enough, it decelerated them collapsing in at the hip substantially, like the most that they ever seen actually. But they still went just as far. And the reason was they hadn't addressed that sagittal plane. When they actually taped the knee to resist the knee collapsing in the flexion, it reduced the velocity and the magnitude of the frontal plane motion because they no longer needed to collapse, as well as it reduced their knee flexion because they could absorb the load without buckling quite so much. So yeah, it's always that going back why, and why are we doing it, and how do you propose that the tape can do that? Is it creating a lot of compression and that force closure mechanism and stabilizing it something, or is it, we talk about things like changing the position. If we can get the force in, we can also change position, and we change position, we can have effects on things like our length tension relationships or where our muscle is functioning. So say a scapula is really downwardly rotated, our lower trapezius middle fibers are really elongated, so they've got that poor force generation capacity. But if we take the weight of the arm, we bring them back up into more mid-range, now the muscle can work better as well and generate more force. So it's not a neurophysiological facilitation, it's a mechanical one because we're just getting them into a better position. Or your tib post, for example, if we bring them into a more supinated position, we just shift that orientation of their subtalar joint axis a bit, but we also increase the lever arm of tibialis posterior. So now for the same work of muscle, we can generate more supination torque. And so it's all looking at those things, lever arms from position or length tension, or just doing some of the work, as we say, directly looking at the kinetics, that compressive aspect and that force closure aspect for, say, our ankle sprains, our syndesmosis, all those sorts of things that we can look at.
No, absolutely. No, it sounds like, like we discussed before, the other day, it's a tape that does what you need it to do in a way, but you need to know what you want it to do, because just now, obviously it came across quite readily, that the research is almost as good as the application, or maybe the application is only as good as research. I don't know which way that works, but if the research is in a way, again, very undefined, like you said, 150 patients all have low back pain more than 3 months, but actually, there's some octogenarians there, then there's some 20-year-olds, a few rugby players, and a couple of babies. I mean, come on, man, it's not really a homogeneous sample, because the actual mechanism of injury is completely different. So in that sense, all of a sudden, then applying the therapeutic effect as well. So it will be very different. And us as clinicians, we can't then go back to the research, because research, I hate to say it, but doesn't really tell us anything. So we come back to, okay, use the crucial 6 inches, trying to figure out what actually is going on with Jimmy here.
Yeah, look, I think that's the case is, it's always N equals 1, when you're in clinic. It's always the person in front of you. And if you look at the research, and look, don't get me wrong, I'm not knocking research, but I think there is research out there that doesn't, that small bits of information are extrapolated to mean a whole lot more than they actually do, or the methodology is such that it's not very effective. And I'll expand on that in a second if we have time. But it's always N equals 1. And that's the thing is, even if a research, an RCT, even systematic reviews that might show lots of RCTs have shown that, people respond or you get significant changes in a certain thing, not everybody in that cohort or in those cohorts responded in that way. Some people may have gotten worse in that, but overall, because the research is looking at a group effect. So that's why case studies are good research as well. There's a need for those. And so they're looking for a group effect. And not everybody behaves the same way as the overall group. And furthermore, often it's saying, yes, the effect was significant, but it's not saying it got them 100% better. And so maybe we need to go do different things to get them even better again. And so it is always, and I think it was Professor David Sackett who coined the term evidence-based medicine. He was sort of saying, don't quote me on this, but something like the literature makes up about 10% of your decision-making in a sense, because yes, you have that, but you also have those patient-specific goals. You have the clinician expertise, and you have the situation-specific factors as well. And so, it's like you might have research showing that, I don't know, the pivot, shift and jerk is the best test for, ACL laxity or whatever. But if your clinician doesn't know the indication when to test for it, or they don't know how to do the test correctly, then that research is out the window, or your patient, it might show dry needling is fantastic for something and your patient doesn't want a needle. Well, then that's out the window as well. And I think the situation thing is the big one, because again, a lot of the patient populations I was working with, you're talking about elite sport in critical, situations, a final at Wimbledon or something like that. Research isn't conducted in that. You can't get the numbers, you're not getting a cohort that has all the same stressors and everything as somebody in the final at Wimbledon with whatever the condition is, and so we're always extrapolating to some extent. And certainly if you look at the rotator cuff type stuff, most of the research is done on your typical, middle-aged sort of 50-year-old male who, doesn't like sleeping on it at night time and comes on when they do this and whatever. Whereas, my guy might be a 25-year-old elite tennis player who only feels that when he hits 100 serves at 230 kilometers an hour. And so they're very different conditions when it comes to that as well. So how much does that research relate to my person in front of me? And that's where we have to adjust it. And then as you say, with the taping specifically, what we try to encourage researchers, and if anybody's looking at doing research, by all means reach out to us, because we've got a good little database of things that have been sent to us that not necessarily published, but that we've also had access to people's projects. But what we try to do to discern some of those effects is to look at what happens if we take them in the short position, with tension on the tape, to really get that bungee idea. For those who haven't seen the tape, it's like a big bungee cord, and we can create 15 kilograms or more of this deceleration and spring back, compared to, say, a kinesiology tape where you're getting less than 100 grams for similar sort of amounts of tape. And you can't get them on in the short position with the kinesio tape because you hit that rigid, they've got a rigid endpoint, so they don't go so far. The dynamic tape goes a lot further so that it can really create that bungee effect. So what we do in our research, often people want to compare a kinesio to dynamic tape. And I'm like, look, we're covering different areas of skin. We're doing different techniques. The best thing to do if we want to improve our understanding of what's going on is to tape one group in the lengthened position, so there's no chance of a mechanical effect, and compare that to taping in the short position with the tension, so we maximize that bungee effect. So we've now got the same skin coverage. So that's really important for a number of things. One is it looks the same to the person wearing it. So that accounts for expectation, which is a really powerful modifier, particularly if you're looking at pain, but also of other things. So it looks the same, because you'll see that with some of the kinesio studies where they've got the kinesio on and they've got these nice patterns in a bright color and everything else. And then their sham tape, or their passive tape, if you like, is a piece of white tape here and a piece of white tape here. Like, just from an expectation point of view, which one is the person going to think's going to work better? Obviously the bright, lots of patterns, looks fantastic, but also they're covering different areas of skin. So from that neurophysiological point of view, you're not even getting the same or similar input into it might just be that one's got more tape on than the other. And so we need to control for all of those things in our research. So And there's been some nice studies that have come out with the dynamic tape where they've done that. And so one that won a string of awards in Australia last year, Nikki Robinson was the lead author, and with some very big tendon researchers in the world, Angie Fearon, Jamie Gator, and they did great study looking at hip adduction, internal rotation, that same similar sort of technique in greater trochanteric pain syndrome women, middle-aged women generally. And what they showed was that, yes, in fact, the ones that they taped in the short position had bigger, much bigger changes in their movement and also improvements in their pain. And their theory behind that is that if you're collapsing more into adduction, internal rotation, that it increases both the tensile load and the overwork, if you like, of your gluteal tendons, but also increases compression over that trochanteric region by stretching it. Essentially creates a force vector inwards that's going to create compression. And we know from lots of work in the past that tendons really don't like that combination of tensile load or overwork combined with compression. That induces tendinopathy most rapidly. Lots of work, Soslowski, docking, and so on. So their idea is if we can change that adduction, internal rotation, we're reducing the compressive loading as well as we're doing some of the work directly to reduce some of the tensile loading. And that showed that had the greater effect. And there's a few studies now that have come out showing that. Yeah, so that's a really critical thing, I think, with the research, is to get the methodology right so that we learn something from it as well. Have it doing what we're aiming to do. Number one, have a group who needs what the intervention is. Number two, because it's no good if that's your idea and just putting it on a whole bunch of people if they don't actually collapse in it all. Then maybe they don't need that. Maybe that's not the contributing factor in that person. So. You need people who need the intervention as well, I think, is important.
Absolutely. So it sounds like, if there are any chiropractic students who are watching the show at the moment, who are maybe going into their dissertation year where you're thinking of doing a research project on something, maybe they need to shoot you a message and see if there's something you need from them. That might be something.
Absolutely. Look, there's a lot, as I say, there's always a need for more research and high quality research. And we're happy. We don't get involved because if we're involved, then suddenly it's biased. But we're happy to advise on the methodology and how to create a good study. And then also what I have done with people in the past is I've had them send me videos of them applying it so that I can say, okay, yeah, that looks great. Or, if you move your line of pull a bit, inferior to that, that you got to get behind the joint more, that's going to give you a bigger effect because you'll be behind the axis of rotation more, whatever it is. But what we want people to be researching is the correct, the effect of a correct technique, not just, tape on skin. Because if you get the technique wrong, as that study shows, if you get the technique wrong, and you know this when you put it on yourself, then it's not going to do anything. You have to be very, position is critical. Your line of pull relative to the axis is critical. You can maximize your leverage sort of effect by starting further away from the joint to give a longer lever arm. There are ways that we can maximize the mechanical effect or the torque that we can produce. And if you don't do those things, you don't get an effect. I mean, you can put it on your arm, and if you put it on in the short position, you're going to feel this big spring. And if you put it on in lengthen, you don't get it. It's as simple as that. And we've got some videos that people have sent us in the past where they've had somebody with with a nerve injury, and they literally have no nerve, so active muscle stuff. But with the tape on, we change their resting position from here to here, and they can push through it because they've got the intact median nerve, and then it just brings it back up to here. So we know we can have this mechanical effect. The body is just a system of levers. It's very important, though, to get hold of that lever, and that's, I think, where a lot of taping techniques break down from a mechanical perspective, is that they're just shifting skin around and soft tissue around because they don't have sufficient hold of that lever that you're trying to effect. And there are ways you can do that as well. You can put holes in things and slip it over the top of something, or you can cut the tape and pass around either side of a lever, or we do a lot of spiraling where we spiral around to get hold of that lever first so we can get a mechanical effect out of it.
No, exactly. So, just should we call it a practical consideration at this point, but how long would you tape something? I mean, of course, that's an unfair question. I realize, how long is a piece of string? you know, but at the end of the day, you know, say you have a simple grade 1 sprain, you know, the athlete, say an ankle sprain, grade 1, typical eversion scenario. Athletes, obviously, if they get go to a chiropractor, they will get the ankle talus released, you know, the other joints as well, and potentially some soft tissue work. Hence, of course, rehab starts straight away. But how long would you, in those circumstances, tape it for? Is it like, is one application and you kind of leave it, or is it more like over the course of 3-4 weeks? How would you?
Yeah, look, it is a difficult question because again, it comes back to what are they going to do with it, you know, and all those sorts of things. It might be, if it happens and it's my tennis player and it's in the final of Wimbledon, then, you know, I'm going to go really strong with some, what we call power bands, double layers, where, you know, and we've got different grades of strength in our tapes. We have the Eco tape has a much higher resistance sooner in range. So it's great for those joints and ligaments like an ankle where there's not a lot of movement, but there's very high forces. So we need the tape to develop high tensile force quickly. And then our other one has much stronger recoil for more that energy storage and return for our tendons and those sorts of things. So, you know, in that case, I'm going to go, you know, some double A's and get it on and just try and get them through that event. And then, you know, then they're not going to be putting that significant load on afterwards. Then I might go for a much lighter one after we've done our treatment afterwards and you know, in the following, you know, couple of weeks as we're rehabbing it. But what I might do then is every time they're going, what we say a transition point. So every time they're going to something that's a bit riskier where they're more likely to re-injure it, then I go heavier again. So if they're starting to run again, if they're starting to cut and weave and change direction, if they're starting to jump and land, then I do that in a controlled sort of way. And then I'd ease off that as well as they're looking good, as my testing is not showing any issues and so on in terms of pain when I load it and all those things. So it is a very individualized thing. You know, in terms of how long you can leave it on, sometimes people leave it on for a week. If it's, say, somebody's back and they're trying to just get some postural, you know, awareness and so on, they might stick it on and leave it on for a week. And again, the idea is, you know, we used to do it with a rigid tape and the person would be sort of stuck up here and then, you know, then they get sore because they're holding it, or, you know, the classic is they don't even use the support in the seat. They perch on the front of the chair then, you know, and hold them, and then they get really sore from the muscles from holding themselves in that position. So we don't use it in that way, but we might use it to give them some awareness of what I don't like the word better, you know, anything within physiological normal is okay, but what's a, you know, a less loaded position perhaps. And when they're going away from that, so that they regularly change position, because that's what we know is good, right? It is changing regularly. All positions are okay as long as you're within physiological normal, but change it regularly. And that's where the tape, it assists them because it's got that recoil so they don't fatigue as quickly. At least that's, you know, what we think. And that's what we see, you know, anecdotally with things. But also that it just is a reminder, just like you might have something buzzing up on your computer, or, you know, people often say, oh, but, you know, it's just working as a reminder. I'm like, yeah, but, you know, or cueing them. I'm like, yes, but isn't that what we do all the time? You know, it's like having your chiropractor or your physio standing with you the whole time and saying, you know, hey, don't forget to straighten up. And when you do straighten up in this way, you know, get some anterior tilt going in your lumbar spine or whatever it is, because we can tape to give them that direct. So it's like it, not only reminding them, but also guiding them with your hands as you do it, you know.
Absolutely. Do you know, coming to this postural thing, I mean, there's a brilliant example of, so I saw this young lad, he's sort of maybe 14, 15 years old and very sort of, you know, more limbs than anything, you know, that kind of typical young lad. And he had really horrible sort of slouchy posture, and his mom was constantly on his case about it, and he was getting a bit upset and whatnot and that. So I treat him once or twice, and then he comes back and he goes, you know, face all lit up. He goes, oh, I got myself this brace, you know, this postural brace. It's brilliant. I'm like, okay, well, whip it on, show me what it does. So there he goes, puts the thing on, and he's sitting there going like this.
Yeah.
So I said, well, does that feel much better? He goes, no. I go, okay, well, whip the thing off. And I kind of just put my hand on his back and the other one on his chest, and I just lift him over like that. Goes, well, is that better? Yeah.
Yeah.
Then a couple of strips of tape, you know what, just a little reminder, like you do the little boxy thing, you know, absolutely brilliant. You know, and he's just, again, that cueing, like you said, you know, it's just, just works, doesn't it?
Yeah, look, and if you actually look at some of the things that are also going on, we talk about, and I stay away, as I say, from that facilitation and inhibition from that neurophysiological point of view, from taped contact with the skin. But you also get it in other ways from changing movement. So, you know, you'll get people who are really overactive up through here, you know, through their levator scapulae and so on. As soon as you actually bring them into a better position and you upwardly rotate the scapula and you switch on, you know, your middle and lower fibers of trapezius, then you get that reciprocal inhibition neurologically anyway of some of those overfiring downward rotators. So by, again, changing position, you do get, you know, switching off of certain muscles and activating of others, but it's the mechanical change in position that's creating it, and they're switching it on, rather than the tapes, stimulation, you know, on the skin. Yeah, and I'm not saying it doesn't do that. I'm just saying that there are certainly, you know, because there are some studies that lead to some suggestions, but again, it's a rigid tape seems to be better than a kinesio for that, because it pulls much harder. So maybe stronger stimulation, there's some on the ankle and things like that. But that's why I say we stay away from it. But we know, you know, I always find it's a really great little clinical, you know, I'd say trick, but, you know, little clinical tool that gets the buy-in on your postural side of things. So I'll get on, you know, those trigger points, for want of a better word, but tender points, you know, on that levator scapula when somebody has that, maybe they've got headaches or whatever, and it's really tender. And then I will just simply come in and I'll correct them from the bottom up, basically, and get them to anteriorly tilt, and then come in and then upwardly rotate that scapula, keeping my finger on that tender point, and then, you know, push it again a bit hard, and they'll just go, it's not sore now. And you can immediately take that off, again, through that you know, reciprocal inhibition, by getting the right things working and the others. And so then they can go, oh, wow. And they can see that direct relationship immediately between their position, working the right muscles, and then their pain or that tenderness. So I think that's just a nice way to get them to understand the importance of regularly changing, using, you know, different muscles and using them correctly. Or, you know, you need to have a stretch and do all that, but...
You know, that is a fantastic little tip. I'm going to try that tomorrow. No, tomorrow. Yeah, tomorrow's Monday. Yeah, I'm back in clinic tomorrow, so I'm definitely going to start using that tomorrow. I'll see how that works, man. I'll let you know.
Let me know. I love it, you know, and I think it's not, I won't take credit for that. I think, and I might be wrong, but I'm pretty sure Gwendolyn Joel, Professor Joel, who was one of our, you know, she's one of my professors in both my bachelor degree and my master's degree from the University of Queensland in Australia, and she's an expert on headaches, cervicogenic headaches.
Right.
And I'll credit her. I'm pretty sure that's something that she showed us during the masters, you know, and I think, but I've used it for years, and I love it. It's just instant, and it's, you know, almost without fail, you know, so.
And you know what, that technique, it might not even originate with her. It might have been some shaman sort of, you know, thousands of years ago who was working this thing out, you know, already.
Absolutely. No, that's right.
No, it's phenomenal. You know, when you start
getting... Yours now, claim it, run with it.
Yeah, it's cool though, because, you know, when you start looking at these things that are, you know, they come across a bit like voodoo, isn't it? When you do that technique to a patient, you know, and they go, well, what did you do? I said, nothing. You did it. You know, you just straightened up. And all of a sudden, the whole system is different. That's what really, I really enjoy. I love doing that. And
like you said with your guy, though, there's some of it is that a young girl springs to mind for me that I had back in the clinic when I worked in Australia. I'm going back probably, that would have been about 2010, so 10 years ago now, no, earlier, 2009. She was sitting for her final high school exams, and she was having all these headaches and everything, came in and, you know, very reactive through her upper cervical spine. And we did some work, and I taped her over what we have called our posture pals, which is, you know, which were actually a precursor to the tape itself. We started with the posture pals, and they're sort of an X shape with a bar across the middle, or we have a couple of different shapes, but to do exactly that. And I put that on, and she left that on for 5 days, and she came back and she said, I haven't had a headache since. And she said, I just didn't know where I was supposed to be. So she didn't know where she didn't have that awareness. And once she knew, and she did it, and so, you know, only saw her the second time and never got her you know, a note back a little while after saying, haven't had a headache since, exams went great, you know, and she was through it. So sometimes it is as simple as that. You know, she was just there loading it all the time. You know, you know, obviously it was a sudden increase in load because she was cramming for all of these exams. So the tissues didn't have the capacity there, signaling off, you know, they're sensitized, whatever else. And so just that sort of vicious cycle. Coming off, unloads it, dampens the whole system down. She knows where to be now, so she's not overloading it. And, you know, simple as that.
Absolutely. And I mean, you know, my little, almost like a pet thing I use a lot is breath, you know, just how do people breathe? But, you know, when I ask the patient to take a deep breath, pretty well, I don't think anyone has done this correctly, if there's a correct way, but everybody breathes.
Yeah.
Up there. Nobody breathes into the diaphragm because generally, you know, nobody ever thinks about it, right?
Yeah.
But as soon as you kind of explain a couple of things, or I explain a couple of things to the patient and why you might want to consider using your diaphragm, you know, maybe reducing the stress and enabling your chest to open a little bit, the postural side of this and that, you know, yeah. So why didn't they teach us that at school?
Yeah.
Because it makes sense, but nobody ever thinks about it. And then like your girl there, you know, obviously she just kind of fell into a habit of doing something, and it never thought about it, never really figured it out. These are the kind of things
like running too, right? Like nobody, you know, people just start running, and we all run differently. And I'm not saying there's a perfect way to run, because obviously we have different setups, and what works for one may not work for another, and so on. But you know, you never, unless you're into the athletics from a young age, most people aren't taught to run. And we used to do quite a lot with triathletes on the Gold Coast. And I remember one of the physios who I worked with, who used to work with the Australian swimming team and so on, the Olympic team and as well. And he'd say, oh, triathletes are often terrible runners, incredible athletes, like really fit athletes and so on. But they've never really had the running training that perhaps your sprinters or your runners have had, because they've just fallen into it because they've, you know, been good at swimming and they just put it all together. And so it's probably changing now, is that whole, you know, is that a lot more professional, I guess, in recent years. And maybe kids start earlier, and there's more grassroots side of things in terms of coaching. But even, you know, not picking on the triathletes, it's your footballers, your whatever, you know. It's
you've got outliers in every sport, you know, who somehow muddle through, you know, with dreadful technique and dreadful form, and they still somehow, you know, manage to do it. You know,
that's right.
Obviously, legendary triathlete Dave Scott, I think he always had a very uneconomical running style. I think one of his things he used to say himself, you know, if he was a dog, he would be put down already. You know, goodness me. And as somebody who's a bit more recent, Lionel Sanders, obviously a very accomplished Ironman triathlete as well. But, you know, it doesn't really look like he's enjoying it when he's running. But you know what? He's going a decent pelt. And
absolutely.
But
that's what people say. Oh, you know, Usain Bolt could do this, that, and the other. And I'm like, are you going to touch it? Are you going to touch his technique when he's the fastest man in the world? And if he's not having problems, if you have to because he's breaking down, that's a different story. But if he's not breaking down and he's doing it, you're going to play around with it too much. I don't know, you know. But you're right. You know, even the British marathon runner, wasn't it Paula Radcliffe? Wasn't it? With interesting technique that worked for her. You know. So.
Yeah, and the same with golfers. You know, you watch any PGA Tour event or European Tour event or any of these. You know, you see there's generally you have the uniform masses, and then you have the outliers, isn't it? You know, who have a bit of a quirk in their swing. And would they be better off without doing it or not? Who knows? Again, you just don't know.
Yeah, look, there are core things I think with any technique for any activity that have to be relatively the same. But you take a group of runners, you're running down the street, and they'll all be completely different. You know? And you'll have some there who naturally look brilliant, and they're smooth and they're fluid, and they're, you know, got good hip extension, and they're running through. And then you have the others who are collapsing down, their heels are kicking out sideways as they run, and whatever, you know, if you look from behind, all those sorts of things. You know, but that's right. It's again, it's identifying how much of what they're doing is impacting on why they're presenting. I think, you know, again, it's always back to asking that question of why why is that, you know, how does that impact what it is I'm looking at here?
That's right. Absolutely. No, that's it's a wonderful world, isn't it? When you start looking at people.
Fascinating. Well, you know, and you know this yourself, but my wife and I have both been physios, you know, a number of times. We can't not notice people now when you're walking down the street or anything else. It's always a comment. Unfortunately, you know, if we're in Vanuatu or if we're in Australia, you know, most of the time we can get away. We can at least speak in Swedish so that, you know, nobody understands, you know, what we're saying. So much so, yeah, makes it a bit safer.
Sorry?
Yeah, makes it a bit safer if we can speak.
Yeah, totally.
Although, mind you, there are a lot of Swedes in Australia, particularly in and around Sydney, and you've got to be a little bit careful. No, we're never nasty, of course. We're never nasty, but it's just observations, you know.
No, absolutely. But, you know, I recognize, I'm laughing because I recognize myself in the same situation. So my wife is also a chiropractor.
Okay.
But we don't have a secret language. She doesn't speak Finnish, but, you know, the point is that, I mean, when we're in the car and we're driving somewhere, you know, there's you know, both of us are looking at this like there's somebody running. Both of us are looking and both of us are kind of going, yeah, don't say anything. And then somebody blurts it out and then our kids go, what are you saying? What are you talking about?
Yeah, no, it's true. And I'm sure everybody who's listening can relate to it, especially if their partner is also a clinician of some description.
That's right. No, exactly.
or a runner, or, you know, and Vilve is both. She's a runner and you know, she sort of run, you know, high level as a junior in Sweden, and so, you know, spent her life, you know, growing up training and running. So she's a physio and a runner. So, you know,
yeah, no,
yeah.
But, you know, it's somebody once told me, I'm not going to do the exact quote because it's a bit rude, but, you know, people can be messed up in so many creative ways, and I think that kind of sums it up, doesn't it? Really.
Yeah, that's right. Yeah, we're all beautiful messes in one way or another.
Oh, absolutely. It's a disaster waiting to happen, one could say. No, absolutely. But you know what? That has been an absolute pleasure having a chat with you this evening, Ryan, or morning for you, obviously. But you know what? I think we're hitting on an hour mark, so we're not gonna make it too long today. We might have to do a second take at some point and carry on a conversation, because this has been brilliant. And you know, I'm looking forward to working more with the dynamic tapes myself. Obviously, those are going to be featured in the FICS extremity seminars, the hands-on seminars, and you know, all of our trainers are obviously proficient in using the dynamic tapes, and we're getting all the wonderful resources from you guys as well. So much appreciated on that. And
absolutely. We're going to be working closely as we can, you know, with the FICS educators and so on. You know, it's a little difficult now with the distance for me to come and do some things, but when that opens up, you know, I'll be coming and doing some more events. We had scheduled to do some, you know, this year in Australia and so on, but we'll do it remotely. And if, as I say, people want to send videos in and have some critiquing and all that sort of stuff, we're more than happy to do that and help people out and learn from a distance that way. You're also going to love what we've got coming out soon, is what we call it is a power band, which is sort of similar to having a double layer of our original tape together. So it gives us a higher resistance, but a much higher recoil. So you don't have to put two layers together. Fantastic. But the reason I say you love it is it's the artwork on that. So those who have seen it will know we have various artwork on our tape from leading artists. The originals from Norfolk Island, which is the originals from Norfolk Island, which is where you know, that's sort of home for us really. My kids were born there and grew up there as well in their younger years. So it has a Norfolk Island design on there, which is, for those who know their history, is where the descendants of the mutiny on the Bounty and their Tahitian wives ended up after Pitcairn Island. They ended up on Norfolk Island, which up until then had been a British convict settlement that was disbanded. And so it's got this Polynesian style, which is the mix of Tahitian and the English sailors. Our Eco tape has a fantastic Australian artist by the name of Luke Malley, who has put his artwork on Indigenous Australian art. In fact, that's one of his behind us there as well. And the reason we have that is that the product is made predominantly out of recycled plastic bottles. The Indigenous Australians have a 60,000, longest continuous history, 60,000 year history of living sustainably, and they have a very strong connection to country. They call it caring for country. They sort of treat the land as like their ancestors, and they bring them to life through song and dance and so on. And very strong connection with the land and looking after it. And he was happy to jump on board with that, symbolising, the care and so on. The new one has my wife's cousin, my wife's grandmother was from Finland and was Sami. And so the new one has artwork done by my wife's cousin. Their extended family still have the reindeer, rearing the reindeer and so on. And it has a Sami, so similar, that's what it represents on the new tape. I don't know if I have any floating around here. I don't. Hang on.
Of course.
I will. Oh, yes, I do. Look at that. I do. Hang on.
Ah, there you go. Oh, yeah. That's the shaman's drums.
That's the drums, right? So it's got the lights flowing through the air and the kota, all the Finnish or Samic design elements. So yeah, there you go. Cool, so he's an artist and a goldsmith and all this sort of stuff. So yeah, they were really happy to be able to share their artwork and these awesome attributes of all our these cultures around the place. Fantastic.
That's really cool, man. No, really appreciate it. And I'm looking forward to getting some of that tape, because that will definitely resonate with me as well.
As soon as we get it, I'll send you some. It's, as I say, we're just waiting on the final samples now of the first big production. So hopefully it's only a couple of months away and then we can get it in everybody's hands. Yeah, I love it. It's all, there's still going to be a role for the others because, you don't need that strength all the time. But it's almost, I guess, in a way, what we were thinking when we first created it, if you like it's sort of got to that level where, because I do use double layers a lot because of the patient population I'm using. So we'll laminate 2 layers together first. For those who aren't familiar with it, don't put one on and then another one on, because they'll sort of shear off. You put 2 together first, separately, and then you put it on the body as one strong piece, and that way it stays really well and you get that much stronger recoil and so on.
Oh, good tip that, actually. Really good tip.
Yeah, look, it is really different to apply to what you're used to doing, some of the handling skills. So we've got a heap of resources on our website. Jump on there and watch the videos on application, the videos on handling, because you can create blisters on the skin really easily because the forces are so much higher. Really easy to avoid, but you just need to do it the right way. There's a clinician area on our website that's free to register. For those in the US and Australia, you'll also get access to professional pricing. We sell directly there. Other countries we don't, but you can access all the distributor information. And I would urge you, if you are speaking to the distributors, just ask them for, make sure you're getting professional pricing. And we're working with them to try to get discounts. We'll also work with them over the coming months to see if we can get a fixed price rate for dynamic tape as well.
Oh, that'd be amazing. Much appreciated. Good stuff, man. Hey, listen, you know what? Exciting as always, and I'm looking forward to our next installment. I'm sure it'll be even better. I'll come up with better questions for you then. But you know what? Really appreciate Ryan. Really appreciate your time, and I'll look forward to the next time. So you look after yourself. Take it easy. Thanks, day.
Cheers. Thanks again. Bye.
Thanks, appreciate it.